Hi, I am Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are Two Peaks in a Pod. Well, hi, everybody. Welcome back, Dr. K.
Yes, it feels good to be back. I had a little hiatus.
Yeah, we took a summer break, but during summer break, something different happened with you. Do you want to tell everybody?
Yeah, so I delivered a baby.
Yay!
The summer was good. It was actually Rainbow Baby for us. Which, someone told me, I think Rainbow Baby Day, right?
Yes, this week.
Yeah,
yes.
So that was kind of sweet.
Yes.
As a reminder, once you're at the success point of your story, it's nice to look back sometimes on what you went through.
Yes. Well, we definitely missed you when you were gone. When we told people you were on maternity leave, they said, she was pregnant? So you really slid under the radar there. That was pretty good.
Some big scrubs.
Yeah. And they said, oh, she must have had a really tiny baby. And I'm like, nope. He's a big baby. Tell them how much.
Yeah, 7 pounds, 10 ounces.
Where were you hiding him?
He was huge. And he's already 11 pounds.
Oh my gosh.
He's so big.
Wow. Okay, well, I wanted to tell you about a patient that I saw whenever you were gone. And my heart really went out to her. She came to me. She was really stressed. She had come from another practice. You know how we always say, we call ourselves the place you go to when you're mad at your first clinic.
Yeah.
And so she had come from another clinic. And she said, look, Dr. Reed, I have been diagnosed with having low ovarian reserve, have low egg counts. I only want to have one baby, but my doctor was really pushing me to do IVF, and I didn't feel right about it. I wasn't ready for it. It just felt more than I wanted to do, and so I wanted to get a second opinion. Do I have to do IVF? Is there anything else I can try? And I said, you came to the right person because absolutely there's so many other things that we can try. And especially when it comes to low egg counts, I think that's one of our biggest pet peeves is sometimes a low AMH is seen, a low egg count. Yeah. And that has just been the driver to force somebody into IVF. But we know that just because you have a low AMH, you still have the same chances of getting pregnant on your own, the same chances of getting pregnant with IUI treatment. And while there may be other reasons to do IVF, like fertility preservation for the future or things like that, it doesn't always necessitate going to IVF. Have you seen any second opinion consults like that too?
Yeah, absolutely.
Yeah.
I think it really stems from, okay, are there benefits to doing IVF initially, right?
Yeah.
If you present and want to do fertility treatment in general, IVF, of course, is our most effective treatment option. It's going to have the highest success rates and the quickest route to pregnancy. So there are certainly benefits to it. So we can understand why your doctor might offer you IVF in that circumstance. And you never want to go back and say, why didn't you tell me I could have done IVF, mm-hmm. right? We never want to be in that circumstance, but it doesn't mean it's the only option.
100%. Yeah. So anyway, so I start seeing this patient and, I do an ultrasound on her and I give her some fertility pills and she responds so nicely to the fertility pills on the follow-up ultrasound. And I say, okay, let's do an IUI. And she says, oh, I don't want to do an IUI. And I'm like, oh no. And I said, okay, well, here I was like your nice natural doctor telling you you didn't need to do IVF. But I'm like, let me explain to you why IUI is helpful. And this is probably one of the most common questions I will get because people will say, why can't I just take fertility pills? Why do I need to do IUI? Is this something that comes up for you too?
Yes, absolutely. Mm-hmm. And I would say as, just kind of tuning in to understand what patient population we're talking about, this is really kind of addressing the unexplained infertility population. Yes. Even though this patient has low egg reserve, right? This is really the studies and the data that's looking at patients who don't have an ovulation disorder or don't have a problem with male factor or sperm disorder. Why do you need to add in an IUI when you're taking fertility pills? I think that's kind of the answer.
Such a good point because a lot of times our patients are friends with each other. Mm-hmm. And so they'll say, well, Dr. Reed, you saw my friend Susie. And you told her all she needed was fertility pills, but now you're telling me I need fertility pills and IUI. So what's the difference there? Well, her friend Susie was not ovulating. How did I know that? Well, she didn't have periods. She would go 6 months without having a period. When you're not having periods, you are not ovulating regularly. And so that becomes a very obvious cause of the fertility issues. And I know we can give you fertility pills, help you to ovulate an egg, and data backs us up that that is going to give you a very good chance of getting pregnant. But that's very different from somebody who's already ovulating. How do I know if somebody's ovulating? If they're having a regular period every single month, we know 95% of those women are already ovulating. And so I say, look, if you take the average person who's been maybe trying for a year, that means if you look back, that patient has ovulated 12 eggs and she's not pregnant. And these are circumstances in which you've checked her fallopian tubes and they're open, and you've checked the sperm and it's normal. So then you have to ask yourself, why are they not getting pregnant? Could it be something else going on? And that's what IUI can really help us with. And so what I ended up doing is explaining to the patient, hey, when I look at your history, I can see you're ovulating on your own. I don't feel like I'm helping you enough with fertility pills. Can fertility pills help you grow extra eggs in a month? Sure. Instead of growing one egg, maybe you'll grow 2 or 3 eggs in a month. But you've already grown 12 eggs before and it didn't work. So why would I think that would help or change anything? Let me boost your chances by just adding on a simple little insemination procedure.
Absolutely. Yeah. And, one of the other sort of downfalls of using certain fertility medications, like the most common one that we use for a patient like this is probably Clomid, right? Is as a side effect, it can affect the cervical mucus.
Yeah.
And so we know from studies that if you don't pair it with inseminations to bypass that cervical mucus, we can kind of be shooting ourselves in the foot from the other side. So that's why even sometimes this conversation is important before we get going on Clomid, right? So that we can make sure we're on the same page when it comes time to do an IUI, because it really should be paired with an IUI, especially for this patient population where we're trying to increase your fertility above that, natural baseline.
Absolutely. And I really love a review I saw where they compared 4 groups. So they had a group that decided to just keep trying on their own, right? Even in somebody with infertility, it doesn't mean you can't get pregnant. It's just you get pregnant with lower efficiency when compared to somebody else. So in general, we think an infertile person probably has about a 5% chance of getting pregnant every month. Okay. So they had a study group that just kept trying on their own. They had a study group that did Clomid. They had a study group that actually did IUI, but no fertility pills. And what they found is all 3 of those groups had the same chances of getting pregnant. And so fertility pills didn't help, IUI didn't help. And it was only the 4th treatment group that did both Clomid and IUI that had triple the chances of any of those other groups, which is amazing. And I think when I tried to understand why that would be, that really kind of circles back to what you were just pointing out. Clomid is great at stimulating the ovaries, but sometimes there's some side effects that can actually work against your fertility. But then when you're pairing that with the insemination, you're able to bypass the side effect. And that's probably why you get the synergistic effect of both Clomid and IUI together.
Yeah, definitely.
Yeah.
And I think people hear a lot about Clomid, and you're familiar with Clomid when you come into a fertility doctor, and IUIs aren't as talked about. And so it is important to know that it's ideal for certain patient populations for those to work synergistically. Right?
Absolutely. Absolutely. So maybe I'll grab my little model here. So I know if you're listening on the podcast, you can't see our model, but if you're on YouTube, you can see it. So we've got my uterus here. Now, my poor uterus has a lot of things wrong with it. You can see polyps and fibroids and endometriosis and everything. But the whole point is just to kind of show you how the IUI works here. And so I've got a little IUI catheter here. And I think the first thing that really surprises people is how tiny and gentle it is.
Yes.
I call it like a little spaghetti noodle.
Yeah.
Right? It's
really
harmless. It's not going to hurt anything. Because sometimes people feel scared. To them, it feels like a procedure. And so they come in thinking, oh gosh, what is she going to do to me? But no, it's just a harmless little tube like that.
There's nothing sharp. No,
Nothing sharp.
no
Yeah.
needles. I think that's like one of the most important things to understand
Yeah. Yeah.
about an IUI. Because anytime someone thinks about getting some sort of procedure done, I worry about anything being sharp.
Yes, yes. Okay, so maybe let's see, can you
Mhm.
help? You're going to do the IUI. Okay, so let me just show you. This is the vagina right here. So if you were having intercourse, the sperm would be starting off here. But what Dr. K is going to do is introduce that little tube through the vagina and then through the cervix
I'm still
here.
getting polyps.
And then right into the uterus right here. Okay. Now, there are some important distinctions to make because sometimes people will say, well, can you get it in the fallopian tube? Well, it's tiny, but it's still too big to fit in a fallopian tube. So it just goes here into the uterus. And then the sperm are still going to have to swim through the tubes to reach the eggs. And then let's see what else. Sometimes people will also ask, is there anything you can do to get the sperm to go to one side or the other? Because when we're doing ultrasound, sometimes we'll say, oh, your eggs grew on the right or your eggs grew on the left or something. But what I think is fascinating is they did this study where I'm surprised they could do this study really, but they did an insemination on women who are about to have a hysterectomy so that they could see where the sperm went. So insemination, hysterectomy, they looked. Well, what they found is the sperm did go to the side where the egg was. And so we think that's because an egg probably releases a chemoattractant that sperm can sense. And so since they knew where to go, that's what I kind of reassured patients. Hey, we put them as close as we can, and then they should know where to go from there.
Yeah.
Yeah.
Your body knows what it's doing.
Yes, yes. Okay, so it's really just as simple as that. But now let's kind of just break down specifically how IUI can be helpful. And I think this is so important because I've heard from many patients that sometimes your doctor will say, oh, do IUI, but they don't really explain to you why it can be helpful. And I know for me as a patient, I need to know those details so I can make an informed decision about whether I want to try something.
Mm-hmm.
I do feel like the most obvious reason to do an insemination is if there's some kind of sperm problem, right?
Absolutely. Yeah. And some of these sperm problems, it's really, obvious as to how it's going to help too,
Yeah.
right? So when we get the semen analysis results back and maybe your partner has low motility, that's the ability of the sperm to swim, and progressive motility, swim forward, you can see how if we bypass so much of that vagina and cervix and get sperm up closer to the egg, it's going to be a lot easier for egg and sperm to get together if they're not so good at swimming and swimming forward. So that's a pretty, obvious reason why. The other part of the IUI that we haven't really talked about is that we actually prep the sperm, we wash it, we concentrate it, right? So we improve these parameters. So if someone has low sperm numbers, sperm counts, or what we call low concentration or oligospermia, this is a great treatment because we are going to concentrate that sperm and then also bypass so much of that attrition or the loss of sperm that's happening in the vagina and at the level of the cervix, and putting it right at the top of the uterus to make it easy for that lower sperm count guy to get his sperm to the egg. So motility, ability to swim, concentration issues, those are really obvious reasons why we would consider an IUI.
Yeah. And even from a patient perspective, you may be able to pick up on some of these things at home, I guess, depending on how much you see. But what I mean by that is sometimes if you just look at the semen can have all different types of consistencies, right? There are some men that, for whatever reason, have a very thick, gelatinous semen. And to me, I picture myself as a little sperm trying to swim through jello, essentially. And I'm like, I can definitely see how this could cause an issue or problem. But when you're doing an insemination and we're washing the sperm, we get rid of all that thick, viscous semen, and we're really just allowing the sperm to have an easier vehicle to swim through, essentially, to get to where they need to go. And then, one of my side hobbies is immunology too. And so one of the things that sometimes people think about is, could there be antibodies that could be sticking to sperm and slowing them down and everything? And so maybe for some people, if we don't know this issue is going on, maybe washing the sperm can help address that and free up some of those sperm to have a better chance at getting to where they need to go. But I think this also brings up an important safety point. Sometimes there's some do-it-yourselfers at home,
Oh gosh.
but it is very important to have the sperm washed if you're going to be injecting it into the uterus. Okay. Now, gosh, it took us a long time to be able to train and learn how to find the cervix and everything. So it always surprises me when some people are trying this type of thing at home, but I
It's a
would
little
not
scary.
recommend that.
Yeah.
But these days I've heard of little, syringe kits and things like that you can do at home. Oftentimes they're talking about just putting it into the vagina. Okay, fine. But you don't want to put unwashed sperm into the uterus because semen has prostaglandins in there. Okay. Now, since the semen usually starts off in the vagina, it's only the sperm that are typically swimming up. But if you take that semen and put it directly into the uterus, that is actually a safety issue. You can even end up having to go to the ER or something because those prostaglandins cause lots of pain and inflammation and problems like that. So that is definitely a big no-no.
Right.
Mm-hmm.
So, if you're at home
Yeah.
having intercourse or you're placing semen in the vagina, your
Yeah.
cervix actually acts to wash the sperm.
Yeah. Mm-hmm.
So there's lots of nooks and crannies or really channels going through the cervix that sperm have to make it up through in order to enter the uterine cavity. And so if you're bypassing that sort of cleansing process, that's where you can get yourself into some dangerous trouble.
Yeah. Yeah. Now, although IUI can be helpful for patients that have low sperm counts, there is kind of a point to where you probably do need to consider IVF, right?
Yeah.
So, one of the common calculations many of us will use is calculating what is the total motile sperm count. In other words, you're taking your semen analysis results, you're taking the volume and multiplying it by the concentration and then multiplying it by the motility and move the decimal over. And that is what gives you your total motile count. And we use those numbers to try to just help prepare a patient to let them know, hey, do we think you have a good or reasonable chance that IUI is going to work for you? Or is that total motile count just so low that maybe we do need to consider moving on to IVF instead?
Right. Yeah. So that's the number. I think, especially my male patients really respond to hearing what their number is and what level they sit at. And we kind of have 3 levels that I counsel my patients. I say, okay, if you're above this, then it is reasonable to use timed intercourse as your treatment. Then you drop below that, and maybe intrauterine insemination is a really good treatment option for you. But if it drops so low, then you're really saying to them, even though it's not a 0% chance that you can get pregnant with an IUI or on your own, it really is an IVF specimen that we're looking at, because with IVF, we can use such smaller numbers of sperm and have success.
Yeah, absolutely. And we would never tell anybody it's impossible to get
Correct.
pregnant at a certain sperm level. But again, it's with what efficiency, right? I always see those people on TV. My doctor said I couldn't get pregnant, and here I am.
Yeah.
And I'm like, who's this doctor telling everybody they can't get pregnant? Like, I mean, you could have had a hysterectomy. I'm still not going to tell you can't get pregnant. Like, there are crazy things that I've seen, some crazy case reports and everything too. So, okay, good. So next, I wanted to talk about vaginal factor. And so really the next 2 things we're going to talk about, vaginal factor and cervical factor, do not get talked about a lot, but I think they're really important. So if you're just having intercourse on your own, the semen and the sperm, they start off in the vagina, but the vagina is a really harsh environment for sperm to survive in. And in fact, sperm can typically only live in the vagina for 1 hour because of the pH. But of course, all my patients, and this is a smart question, I think, say, okay, well, if that's true, what if I just change the pH of my vagina?
I've actually never had a patient.
Mine are very, I'm like, yeah, but because here's the thing, the pH of the uterus is different. The uterus is so much more friendly to sperm, and studies have shown sperm can just be swimming around in the uterus for up to 5 days. And so that's what people say, well, I'll just change the vaginal pH. And I say, oh my gosh, don't do that, because it's important to have a really harsh vaginal pH. That is what keeps our vagina healthy, right?
How are they suggesting they change the pH with some yogurts or like what?
Probably. Yeah. I mean, there's all types of things online these days.
Gosh.
But that harsh pH is what kills off bad bacteria, right? So we want you to have a vagina with a harsh pH because that's going to help you keep a healthy vagina. And I worry if you try to change your own pH of your vagina that you're going to get infections.
Definitely.
you
Yeah.
know?
Yeah.
So I think you could get bacterial vaginosis or really any other type of infection as well. So don't try to do it yourself on that one. But what's the benefit then? Well, if we are bypassing the vagina completely using our little insemination to get the sperm to the more favorable environment, then for some people that's going to help. The reason I think it doesn't get talked about a lot is, people really want a diagnosis. They want somebody, for example, to come say, your problem is vaginal factor, right? But we don't really have a way to diagnose that. We just know in general that the vaginal area has a harsh pH. And so because there's not really a way to assess for that and assign that diagnosis, I think that's why maybe it doesn't get talked about as much.
Yeah. And, these are tests that people really used to look into 40, 50 years ago.
That's true.
When they didn't have such advanced technology that
That's
we
true.
have to just bypass these, right? So
Mhm.
our treatment options like IUI and IVF very quickly correct these sort of factors.
Mhm.
But there were a lot of men back in the day that
Yeah.
really looked into this.
That's
so
true.
it can be studied. It's just not these aren't common tests that we're doing all the time.
Yeah, absolutely. Okay, so that is going to kind of take us to cervical factor. I'm kind of thinking we can divide cervical factor into maybe like cervical mucus and then the cervix itself. The fact that you mentioned that, like, Pat, do you remember, have you heard about the postcoital test way back then?
Yeah.
I mean, this is interesting, right?
Yeah.
That used to be one of the old tests is I guess you would have intercourse and then the doctor would want to take some of your mucus to, I guess, look at the sperm swimming through your mucus and then make some assumptions about that. But it turned out that wasn't really proven to be very helpful, right?
Yeah. And it's not going to change our management as, in modern treatment.
Yeah. I think really we're just like, well, just bypass it. Just do IUI, right? But the first thing I just wanted to mention with the cervix, and I accidentally offended somebody the other day, one of the guys, because I'm getting ready to do the insemination. I've got my speculum in there, and her cervix was so high up. Okay. I had to get the long speculum. And even with the long speculum, I can barely reach it. I'm like, oh my goodness. And so I said, well, no wonder y'all are having trouble getting pregnant. Your cervix is so high. How can anybody reach this? And I think he thought that was me saying something about his manhood. And he said, I'm just fine. Thank you very much. And I said, oh, no, sorry. I wasn't meaning that at all. But I do feel like in models and textbooks, they always show the cervix like it's right in the middle.
Yeah.
But I mean, they can end up in some tricky spots, right?
Absolutely. Tucked up. And, sometimes even we can see this with secondary infertility. Like I've seen after C-sections when, the way they're closed, like it pulls the cervix way up. Very difficult for me to access. It's in a totally different place than it was previously.
Yeah. So for our YouTubers, I'll try to show you. So let's say this is the cervix and let's say this is penis, right? So usually you would think it would be right on, right? But the cervix can be, she was talking about if you've had a C-section, sometimes it's like this. Your cervix is essentially facing the ceiling. Well, that obviously makes it really difficult. Or I've seen it down, or I've even seen it flip back like that. And so you're like, well, of course, that's going to be an issue. But the problem is that may not be apparent on an ultrasound. And on an exam, sometimes you're just going in there to do the exam. You may not be really thinking about it at the moment of, hey, maybe this is a cause for fertility issues. So again, I feel like this is an under-recognized fertility factor, the cervical factor, that people don't really get a chance to really know and understand that could be causing their issues. And especially too, I think it's important when you mentioned C-section, right? This might be a person who got pregnant easily before. Now they're not, and they don't know why. But as you're mentioning, it might just be a little bit of scar tissue is putting the cervix in a position that is different and more difficult to get to.
Yes, absolutely.
Yeah. Okay, let's also talk about the cervical mucus. All right, so for women who are very in touch with their bodies, oftentimes as you get close to ovulation, you start getting clear, stretchy vaginal discharge. This is totally normal and it's a good thing. It usually means your estrogen levels are nice and high at that moment. So that's what should happen. But sometimes we get patients who say, no, I checked for that. I never had that.
True.
Okay.
Yeah.
And I don't, why would a woman not make discharge? Sometimes we don't know. I mean, of course it could be that you're not growing a follicle, you're not making the right hormones, but in someone where all that all looks good, sometimes we just don't know why they're not making that favorable discharge. But I can certainly understand how it's harder for the sperm to get through if they don't have that discharge to kind of help them along the way, right?
Yeah, having that discharge present is essential. So it really triggers cervical mucus and discharge that doesn't allow sperm to get through the cervix, and then it changes completely once you have
Mm-hmm.
these high estrogen. And what Dr. Reed said is really important. I think a lot of people don't understand this. This happens before you ovulate,
Mm-hmm.
right? So
Yeah.
remember, we always tell our patients have intercourse before ovulation.
Mm-hmm.
So tracking your cervical mucus can be extremely helpful, because once you see that shift, you're probably going to ovulate, a couple of days after that,
Mm-hmm.
right? So a lot of people say, well, I'm ovulating because my
Mm-hmm.
cervical mucus is changing. They're really panicked that we miss ovulation or something like
Yeah.
that. No, it's a good sign.
Yeah.
Your cervical mucus is changing because your estrogen is high and you're going to ovulate soon. It doesn't
Yeah.
mean that you have already ovulated.
Mm-hmm. Absolutely. Yeah. Now, I will say, just this is a shout out for our IVF patients because I just got this portal message today. If you're doing IVF and you have lots of clear, stretchy discharge, don't worry. That's just because your
Yeah,
estrogen levels are higher than
exactly.
normal. It
Yeah.
doesn't mean you're about to ovulate.
Yeah.
In general, we usually are managing that differently. But yes, for our IUI patients, that's absolutely the case. And then, as Dr. K had mentioned earlier, remember if you're on Clomid or certain fertility medications, it may thin out that discharge. So, how does IUI help you then? Well, if you usually have discharge here, and it's usually helpful to the sperm, but you either don't make favorable discharge because you have some sort of issue on your own, or you're taking fertility medication that's affecting your discharge, then just bypassing that area, getting the sperm straight into the uterus is going to take away that factor that would normally potentially lower your chances of getting pregnant too. Okay, now I want to go back to the cervix again because we talked about position of the cervix, we talked about cervical discharge, but the cervical canal.
Yes.
Woo,
Yeah.
okay.
Or the opening.
The opening to the
Yeah.
cervix is very interesting because this is where textbooks and models always do us wrong because they always show the cervix like a straight tube.
Mm-hmm.
Don't you wish it was like that every single time?
That would make we've probably taken years off of our lives trying to get into some of these services.
Oh my gosh, our jobs would be so much easier. And the thing is, we can never tell ahead of time what somebody's cervix is going to be like. I will tell you 90% of the time you put that tube in and it goes right in.
Mm-hmm.
But there are some times where getting through the cervix is like hitting a brick wall.
Yeah. And even on the same person.
Yeah.
On a different
That's
day.
true. Yes. Yeah.
It's just, it really is strange how it can change. But, what we're referring to really is the cervical opening.
Mm-hmm.
It's sometimes called the Oz, right? It's like, if you imagine a donut, it's like the little part where the donut hole, right, would come out. So it's the opening. And it leads to a little canal and goes up to the uterus. Obviously, sperm has to pass through this in order to, get you successfully pregnant. And you can have a lot of reasons why this is not super straightforward. So, nowadays we're really good with our cervical cancer screening, right? So some people may have had procedures done to their cervix. Maybe if you've had an abnormal pap smear in the past, you've had a LEEP procedure or a cone procedure where they take off a small piece of your cervix. That can lead to some scarring, and we call that cervical stenosis, or narrowing of the actual opening. And that can really make it difficult to get through your cervix, and probably even affect some of the glands and things that are producing mucus. So there can kind of be two ways that it's affecting things. But, we hypothesize that that's probably affecting sperm, right? If we're having a really hard time getting through, then probably the sperm is as well. So you could have had a procedure. You could just be born that way. Some people just have a really small cervical opening, cervical canal, or it can be very unusually shaped. What Dr. Reed's alluding to is sometimes they're just like these windy or corkscrew paths even going through, not just this very straight shot through. And you can imagine that's really hard for sperm to navigate. Sperm are having to do like some gymnastics getting through there.
Yeah. And I mean, what's crazy to me too is, sometimes it can be kinked like this. And think of a garden hose that's kinked. the water's not going to get through. Well, imagine if you have a kinked cervix, the sperm's not going to get through. But as she was alluding to sometimes too, it can vary by the day. So one doctor may say, and it's always hard too when you're that doctor who struggled and then the next doctor comes in and it's easy and you're like, hey, like, let me explain, right? Because sometimes, for example, your bladder sits right on top of here, right? So maybe can you put your hand as the bladder?
Yeah.
Okay, so as the bladder fills up, it can straighten out that kink sometimes. So that can sometimes make it a lot easier when maybe on a different day it was really difficult too.
And it's not always the same for all patients. Some patients it's easier with an empty bladder. Some patients
that's
it's
true.
easier with a full bladder.
Yes.
And it just depends.
And sometimes the full bladder can work against you too. If it's
Yeah.
too full, like it's a difficult situation sometimes. But ultimately, here's what I tell patients. If you are really seeing me struggle with your cervix, it's a good thing because you're probably the person it's going to help the most, right? And so that's what I think this is really kind of underestimated how important cervical factor is for fertility. Now, just kind of another thing that I think about, if I see a very narrow or kinked cervix or something like that, I also think, could this patient be at higher risk for having endometriosis? So endometriosis is a condition where when you have your period, it backflows through your fallopian tubes and implants in the near the ovaries, the tubes in the pelvis, and it can create inflammation and fertility problems. But to me, it makes a lot of sense. If your cervix is so narrow that menstrual blood struggles to come out and it backflows, okay, you can put the pieces together and determine those things may be linked together as well. So I feel like you can get a lot of information even from doing an IUI.
Yeah.
Even if you don't get pregnant and I did an IUI on you and I really struggled, I'm writing that down in your chart of like, hey, I think there's some cervical factor here. These are some other things that I need to be thinking about too. So I really always like that concept of when you're doing a treatment cycle with us, we're trying to get you pregnant, but we're also learning more about your body as we go along too. Okay, so we talked about male factors, we talked about vaginal factors, cervical factors, and then there's a group of patients too that need help with an insemination. So let's take a minute to talk about maybe single mothers by choice and same-sex couples and everything too, to just kind of talk about how IUI can be helpful for them as well.
Yeah, so I mean, with same-sex couples or women who are opting to do an IUI themselves, right? They're missing sperm, obviously. So oftentimes you'll order donor sperm from a bank or from a known donor that you know. And while some people might opt to do home inseminations, we have a lot of patients that will come to see us to do intrauterine inseminations, right? Higher success rates, obviously, when we're doing it this way. I think there's lots of reasons why an IUI would help you in this circumstance compared to just doing it at home. We're setting you up for success on the back end because we're monitoring your cycle. We know exactly when you're going to ovulate. So a lot of that is, stacking the deck in our favor, but also putting sperm up at the top of the uterus in the same way that we just described is going to increase pregnancy rates for these patients as well. A lot of times by the time same-sex couples, for example, are coming to see me, they've already tried home insemination. So it is kind of similar to trying, intercourse at home and then moving forward with IUIs.
Yeah, absolutely. Well, one of the things that really has been surprising me lately is my patients have been sharing with me the cost of donor sperm. I mean, it used to be, I thought, around $600 to $1,000. Okay. I've had some patients over the last week who told me they paid $2,500.
I just looked at this today.
I'm like, what kind of donor do you have? I'm like, let me see some pictures of this donor. I mean, this must have been a nice donor. My goodness. So when you're really making that investment with sperm, you want to make sure it's put in at the right time, as close to the egg or eggs as possible. You really want to have the best chances there. So I think that's why a lot of people decide to have a bit of assistance with that as well. Okay, let me ask you a question. So sometimes when I'm doing an IUI, of course, the patient wants the very best chances it's going to work. And so they tell me, Dr. Reed, I think I want to do a double IUI. So I wanted to get your thoughts on this. Do you offer a double IUI? Do you think it helps?
Yeah, the way I approach this is kind of how I approach a lot of treatment options. What does the data show? And then what's the risk versus benefits, right? So the data shows there's probably not much of a difference between doing a double IUI. Just simply means an IUI back-to-back days, right? Doing 2 versus 1. So pregnancy rates are similar for patients who do 2 versus 1 IUI. But, let's talk about what are the risks versus benefits. If there is any benefit for patients, the risk is really low, right? What are the
Yeah.
downsides of it? The downsides that I counsel my patient is might have to miss school or work another day, right, to come in for an IUI. So it's more cumbersome and then it's an increased cost, right? So you're going to double your cost of your IUI. To some people, those things aren't really important. And if they feel like there's any, benefit to doing it, then why not? There's not really a risk,
Yeah.
right? There really isn't a big medical risk to doing two. I really don't do a lot of double IUIs. I have had patients that it's very important to them, and that's how I counsel them, and I'm willing to do it, but it's not my standard.
Yeah, and you know what? You kind of just made me think of something else too, which might make it more reasonable. Not even so does it help our chances, but in a lot of our patients, we're really combining intercourse and IUI, right? But sometimes I have patients who can't have intercourse.
Mm-hmm.
Maybe that's the reason they're doing their IUI, which I guess I should have added that in when we were talking about our other factors, right? So why can they not have intercourse? Well, sometimes there are men who have trouble getting and maintaining an erection, or maybe they have trouble ejaculating during intercourse, or sometimes they have patients that have a condition called vaginismus where they have so much pain or a lot of muscle spasms that they can't have intercourse. And so patients in that circumstance may feel like they're missing out because they may say, well, if it's the average patient, they get to have intercourse these several days during the fertile period plus an IUI, but I only get to do the IUI. I feel like I'm missing out. So in that circumstance, could I consider doing a double IUI too? And, I think it could be reasonable in those circumstances. I don't think it's necessary, but I think it certainly could be reasonable. I understand the logic there.
Yeah.
Yeah.
Sure.
Okay. Have you heard of this device called, I don't know if I should say the name. Hopefully they're not going to sue us or anything, but maybe I'll just say vaguely, it's a cervical cap. Okay. So it's kind of a do-it-yourself thing at home. Okay. It's a cervical cap. And I guess your partner gives you your sperm sample and you put the sample in the cervical cap and then you put it in the vagina yourself and hold it up next to the cervix. Now, I looked at their marketing because I thought it was interesting. And they're claiming, I think, that it's just as effective as IUI. But when they give their IUI rates, they gave a very low number. And I'm like, I feel like it's deceptive in their marketing when they describe their results according or maybe compared to some other study that they found that had lower chances for success.
People
So
love to use that as their control. Anyone that's looking
Yeah.
at IUI success rates, they find some study that has the lowest success rates for
Yeah.
IUIs to show that their product is good.
Right, exactly. And because we have this, a marketer came to and tried to say, oh, compared to IUI rate of 6%. And I said, 6%?
Yeah.
And I'm like, what are you talking about? Now, I guess that's a good point to bring up. What are chances of successful IUI when you pair it with fertility medication? We are generally looking at about 15 to 20% each time you try. So I do always say it's good to mentally prepare yourself for the fact that, hey, this could take multiple cycles to have a good chance of it working. But when you look at the cumulative pregnancy rate after 3 cycles, some of that can add up and really give you a very reasonable chance of conceiving, especially if you're on the younger side.
Yeah, absolutely. I talk to my patients about cumulative success rate.
Yeah.
So going back to the cervical cap,
Yes.
it makes me laugh though because, okay, they're going to take it, put it, and then pop it in there.
Yeah.
But, we know from studies that sperm are actually ejaculated fast.
Yeah.
They come out fast,
Yeah.
right? So I'm like, why not just have intercourse where they can come out miles per hour?
Right. You're going to slow them down.
As opposed to put it here and then slap it.
You gave them a rest stop.
I know. Like, it's just logically to me, I'm like, I would want them coming out as quickly as possible.
I like that. I haven't really thought about the velocity of sperm, but I think that's a good point. Yeah. You don't really get the oomph that you get with intercourse. Yeah. So I can understand for same-sex couples, single mothers by choice using donor sperm, you don't have the option to have intercourse. I do think that makes sense. But if you truly have infertility, as we've been discussing, I don't think you should do it because first, this cervical cap is still expensive. Okay. And to me, you're just putting the sperm still down here in the vagina, right? You're
Very
not
similar.
bypassing the mucus. You're not bypassing the cervix and all of this. So I don't really feel there's much benefit. Now I'm sure a bunch of people are going to be like, well, I got pregnant using it. Okay. I'm not saying it's impossible to get pregnant with it, right? Again, everybody, even somebody not doing anything has a 5% chance of getting pregnant every month, but I don't think it has as great of an efficiency as IUI has.
Correct.
Okay. I wanted to talk about people who are not a good candidate for IUI. So, obviously, you've heard me just rave about IUI and how much I love it, but certainly we get people who want to do IUI, and I'm like, not the best option, right?
Right, absolutely. So we kind of mentioned in terms of male factor what
Mhm.
might be limiting there. So there are certain concentrations of sperm. If the sperm counts are just too low, right, or when your parameters are too low, then it's really not good to move forward with IUIs. Not because it's impossible for them to work, like we've said, just the likelihood of it working is lower, and we might string you along for a longer period of time, and ultimately you may have to move forward with a higher level of treatment like IVF anyways. So we don't want to waste time and money that you should have maybe been putting towards IVF.
Yeah, absolutely. And I do think maybe another population where I at least like to bring it up and talk about it is maybe late 30s, early 40s, because can I help you get pregnant with IUI? Yes. But then are you going to want more after that? Because if so, this might be our opportunity to consider doing IVF, not to necessarily get you pregnant in this moment, but to also have the opportunity to freeze embryos for later, because once they're frozen in time. So even if you're older at that point, you may have a better chance at having a second, a third, or more children if we had taken the opportunity to do that treatment, even if we didn't necessarily need the treatment at that time.
Right. The other thing that's really important is that your fallopian tubes need to be open. So,
Yes.
most of the time, we're going to be doing tests to make sure that both tubes, or at least one tube, is open. So, we have to have that internal machinery working
Yeah.
because we can't bypass the fallopian tubes when we're doing an
Mhm.
IUI. So, if your tubes are both blocked on both sides, then that is really an indication to proceed with IVF.
Yeah. How many IUIs do you think somebody should try before you move on to IVF? So if they're not working, do you just keep trying, or do you have kind of a number in mind where you're like,
Yeah.
maybe we should move on to IVF?
So I counsel my patients a lot about cumulative success rate, because what I really think is a challenge is sometimes people want to do one IUI, right? People
Mhm.
either fall into like, I
Mhm.
want this one to work, or they want to do a bunch.
Yeah. Yeah.
There's really hardly any of these moderate
Yeah.
patients, right?
Yeah.
But what the studies really tell us is that if you're going to do IUIs, you really need to commit to giving it the good college try,
Mhm.
right? So I say, let's do at least 3 IUIs
Mhm.
before we panic,
Mhm.
right? And say this treatment option isn't working for you. Let's explore something like IVF or higher level treatment options.
Mhm.
And I usually sit down after that 3 failed, I hate the word failed, but
Yeah.
unsuccessful IUIs, and discuss what else could we do? What could we do
Mhm.
differently? Do we need to pause and do some of this more rare testing,
Yeah.
investigation? And it doesn't mean that we can't do, IUIs 4, 5, and 6. It
Yeah.
just means we need to regroup, make sure we're not missing anything, and consider, is this the right path for us to stay down? Certain couples, I'm definitely going to encourage more so to move forward with IVF
Yeah.
versus other couples. I think, hey, it is really reasonable for you to try 4, 5, and 6. For example, maybe I have a sperm issue and a patient that's not
Mhm.
ovulating.
Yeah.
It's really like the first time they're ever able to try, right?
Yeah.
If someone
Right.
hasn't been ovulating and the sperm counts haven't looked great when they've been trying at home on their
Yeah.
own, they weren't really trying. They didn't
Yeah.
really have an opportunity each month.
Yeah.
So if you do 3 IUI, rounds, that's like 3 months of trying. No one would give up after 3 months of trying.
Yeah.
So I really try and gauge it towards what's the prognosis and the diagnosis of the
Yeah.
couple itself. If it, on the other hand, is a couple with unexplained
Mhm.
infertility, right? And they've been trying and
Mhm.
she's ovulating and the semen analysis looks normal and they tried already for over a year at home and we're still not having success, that might be someone that I'm worried there might be something else going on.
Yeah, absolutely. Well, it sounds like you have a really personalized
Yeah.
approach, which I think is great. I think some people just kind of have an exact number in mind and they don't really customize it according to the patient. So I like that, how you really
Mhm.
consider their history when you're thinking about that too. So, and then, okay, finally, I wanted to talk about the cost of IUI. I think this is important to factor in. There's so many patients that don't really have much help from their insurance company. And I have so many people that come to see me for their new patient visit, and I do actually review cost with them, and they are so relieved. They say, "That's it? I thought IUI was going to be thousands and thousands of dollars." And I say, "Well, IVF is." I'm like, "IVF is like buying a car."
Yeah.
But I'm like, IUI treatment is so much more affordable, and so I thought I would just kind of quickly describe cost. Now, my disclaimers are this is one cost here, which may not be, maybe your clinic could be thousands of dollars. I don't know. Number two, it's cost this month, which is August
Okay.
2025.
Yeah.
So it can change, right? We
Yeah.
never know when costs are going to change and everything. But let's talk about somebody who has no insurance coverage at all. You are usually looking at doing 2 ultrasounds, a baseline ultrasound, and then a follow-up ultrasound to check for the follicles, and then the IUI. Each ultrasound is $250. The cost of the IUI is $500. The cost of the medications is usually less than $100. So when you put that all together, you're really looking at just a little over $1,000 to do an IUI cycle. I guess it is still expensive overall, right? But when you compare it to IVF, which is probably around $23,000 or so, it ends up being a treatment that is both more convenient because there's less appointments and uses less resources too. And so that's why I think it's definitely reasonable to give it a try sometimes before moving on to IVF.
Totally. A couple of things to consider in terms of cost too.
Mm-hmm.
Right? We just talked about cumulative success rates. So you really should think in your mind, okay, I'm committing to like at least $3,000 if we're going to do this treatment. And then Dr. Shelby Neal did a nice study looking at cost comparison with patients who, proceeded immediately with going just to IVF, right? Or trying IUIs first. And ultimately, there can be some benefit to not doing IUIs, right? And going straight to IVF because patients who did explore IVF first can have lower treatment cost overall. Why is that? Because if your IUIs are not going to be successful, then you pay $3,000 and then you have to move forward with IVF. So it is something that I'm always straightforward with my patients about, and say there is always a chance that we might take you through these IUI treatments and then we still have to pay for IVF later. So cost is a really tricky thing to really compare. Right? But you're going to be so happy if you do get pregnant off of one of the first 3 IUIs.
Absolutely. I think that's a really good point, especially too if you're talking about people who want to try more IUIs than the average person, right? Let's say they want to do 8 IUIs or something, right? Then we're talking $8,000 that you could have used towards an IVF cycle. So that's where it kind of becomes like, hey, let's give you more of a natural chance with IUI, but also we don't want to be wasteful of resources either. So yeah. Okay, good. Well, I feel like we talked about a lot today. Are we ready to wrap it up? Okay, perfect. All right. We'll see you guys next week. Bye.